not prepared to not succeed, to have failure of trance or hypnosis like we have planned it to do. So we are also not in a psychological setting. We are not sitting in a chair and are very quiet and everything is fine around. So we have the pressure of our audience in the operating room. We are all the staff, the surgeons, nurses. They are looking at us, what she's doing, and you have to confront this. Yes, okay. And very often, in the beginning, you have a lack of appreciation by your surgical colleagues, and then you have to stand yourself and go forward, and then don't be shy to do what you have planned to do. So the different circumstances in hospital settings. So we don't have a chair, the patient is not coming to us to talk about his problems, there's completely other conditions. So there is already pre-existing high suggestibility, so even the patients are sometimes in a natural trance. Unfortunately, this is very often a negative trance, so they try to escape to this harming environment, from this harming environment into an internal place of security. So they are focused on themselves, and especially for children, they feel helpless, they're separated from their parents, and they suffer, and this is a passive suffering. They can't do active, they just have to obey and do what the adults are saying. So you can, in the operating room, when you do surgery or unpleasant interventions, you can do hypnosis in different ways. In anesthesia settings, you can have an hypnosis like a supplement tool, but you can also use it like hypnosis only. For example, to put on a PVC line, everything. But you can also combine this with local anesthesia or regional anesthesia. You can do some nitrous sedation if you need to. Even you can have a facial mask and an inhalation of nitrous oxide, which is very appreciated by children when they can play a pilot story like this. And you can combine also hypnosis for a simple, normal induction of general anesthesia. So I very often ask, how many times in hospital do you make hypnosis? I make it always, every day, and all the time. Okay, the positive signs help us in this setting. So I have a high suggestibility by the patient, and I can use this. I have a hypokinesia and a muscle relaxation. So my patient, when he's in a good trance, he won't pull off his hand when we are operating on it, so he will be calm and don't jump off the table. We have different techniques to reinforce, to confirm, to verify. So these are techniques we all know. So especially in anesthesia, the mixture of all this is very important. You have to adapt your hypnosis every time individually on the patient situation. We also know that pain perception is very close together, and the emotional point of pain is very important. So if that doesn't scare me, it doesn't hurt me that much. So hypnosis will have an impact on the demand of analgesics after an intervention. The time until alimentation after surgery could be faster, and even a shorter period of hospitalization can occur. In pediatrics, hypnosis is perfect to apply because children, they have naturally a high suggestibility. ably slip into an imaginary world. Most of the time they slip just without anything. They do this alone. So they appreciate a playful dimension, and when you have a surgical intervention or diagnostics or something else is very, very unpleasant, it's favorable to have a story with an activity, so doing sports, treating animals, so you can combine the story with the reality who's outside the dissociation. So when the children are touched during an intervention and there's a stitch, there's a local anesthesia or something else, you can combine this in the story. Oh, there was the little crab you had in the sand, it was stitching you, biting you, it's not very bad, so okay, we can go further. So this is a reinterpretation of different stimuli during the story and during the surgery. So this will overall reduce the post-operative pain, also and the anxiety in the awakening room. They will consume less analgesics, and they will have also a better PVC tolerance and dressings. We all know children are in the awakening room when they're forced to fall asleep, and they wake up and they, I will have this off and everything, and this is the biggest fight. It's not the pain, it's not the separation of the patient, it's just the dressing. And this is not necessary when we have an hypnotic approach before. So I have a little case report. This is a 12-year-old boy, like I told you. We had a hypnotic approach. He chose his mountain bike riding tour. So he had the choice to have a starting number for the mountain bike race with a colored bandage. And so we could put in a normal trance the PVC line in his arm without any reaction and any problem. So then he came back to us, and we had to wait 10 minutes to go into the OR to continue, and he was happy. And this was also the technique of fractioning. So we re-trans, and so he continued just his mountain bike story, and so the removal of the metal in the elbow from the removal of the first wire happened without any problems. But we will continue with Kilian's story later on. But now we'll talk about hypnosis in unusual hypnotic settings where you sometimes even don't think you can apply hypnosis. This is in our anesthesiological field, the intensive care unit. The big problem is many patients are analogous sedated, and then they have a very high average of age. We are very often limited in our communication with them by dementia and delirium, and they are restricted with movements, there is pain, and there's a lot of psychological stress and anxiety. And on the other side, the high-tech medicine is the major priority. So we don't have many time, and the tight schedule for our staff is not really favorable for to do hypnosis in a serious way. Absolutely no preferable circumstances for hypnosis, but you can, even there, hypnosis works, and I have an example and case report. It's very astonishing. So this was a 40-year-old man. He had a sepsis after an esophageal perforation with mediastinal abscess. He was finally extubated after 3 days, and he had a swallowing test for the esophagus, and there was no leakage, everything's fine, a good passage, but the testing of oral nutrition, he was not able even to swallow a little sip of water. He told me that it stuck right in there, so he couldn't eat. And but he was very stressed. He was orientated, very cooperative, but he didn't sleep the last. It was on POD 6, so he hadn't slept for 3 or 4 days. So he was very stressed. And then he had also, since several days, a recurrent tachycardia went up to more than 200 beats per minute sometimes, and a steady state of cardiac rate of about 120 constantly, and he didn't react when he had these tachycardia periods of 200 for any medication. And then the supplement was that he started to have hiccups. Very, very strong hiccups, very painfully hiccups, and then he had medication and everything, but these hiccups were continuing more than 10 hours, and was really resistant to everything. So our surgeons and us also, we are very scared for surgical complication. He had already had a rupture of the esophagus, so we had planned an abdominal thoracic CT scan for tentative diagnosis of subphrenic abscesses or problems in the mediastinus. So this was a really serious problem we attended to, and the patient was even prepared to go to the OR once again, perhaps the next day after diagnosis. So then I didn't expect to help him with his abscess or something else, but I just went to him to calm down. He was really stressed before this tachycardia, so I tried to make a little hypnosis. I just went to him, I shook his hands, and he was in trance in a few seconds. It was very astonishing. And the immediate relaxation of his feature and his breath could be observed, and even the heart rate has based immediately, because I was in front of the monitor. I could see that the heart rate was basing from 120 to 80, and the hiccups were gone. So we did a little hypnosis for detention, about 15 minutes. I didn't give him special suggestions. They were not symptom focused. They were just to relax, to profit of the oxygen he has in his nose. This will give him energy to recover and everything. And it worked. So after the hypnosis, his heart rate was normal, about 80, and the hiccups were still gone. The patient was very calm. When I came back the next day, he told me he had slept the whole afternoon, the whole night. He felt absolutely regenerated this day, and he was eating his noodles and sauce on the day before. He wasn't able to swallow a sip of water. He had bowel movements, which is very important in the CQ, you know. And the CT scan schedule was cancelled. There was no surgery, there was no CT scan. The patient was discharged from the intensive care unit 3 days later. So this was working wonderful, perfect, better than expected. But what we can do when we expect that it's working all the time? Our ambitions are very high. We have our success, but there is also failure. But should we call this failure? First of all, for sure, you have to think positive. That is the empathy and the confidence, very important. You don't have to start with the ambition to do a big hypnosis and a big trance immediately. So you just have to, first of all, to reinterpret the potential negative sentiments, to give children, for example, an active part in this situation. And you just have to offer your accompaniment and create a trusting relationship. So like Jeffrey Zeig yesterday said, hypnosis, this is not a technique, it's just a relationship, correlation. So next thing is to avoid nocebos. Nocebo is the adverse, like I said, to placebo. So with the placebo you can do good things, it can be a drug, it can be words, good suggestions, but when you not choose the right words, you can have a nocebo effect who will harm the patient and not very good for his healing process. So if you avoid nocebos like positive negations, noise around the unnecessary announcement of pain. So now I will put your PVC line on and this will hurt a little thing, but you have no fear, it won't hurt that much. So, okay, the patient is very calm and you know what I mean. So you have to choose the words. You put the PVC line in and it will be good, and then we can help you to fall asleep in a simple way, and you can choose your dream, for example. But there's also tactile nocebos. So I see it very often with my younger colleagues. So they will put on the facial mask. They're very not brutal. They're not brutal, but they just put it on because they think it's very important. And then they cover the eyes of the patient. The patient is not able anymore to communicate with me, even with the eyes. So this can be very, very injury of intimacy and non-respect of the patient's psychological problems. So the therapeutic relationship is the most important. And what is, when we try to do hypnosis, it works most of the time, but what we do, what's about when there's no sufficient trance? Is this a failure? We have to change something. So we come back to the case report of Kilian, who made his mountain bike race. So remember that the first wire on his elbow was easily removable under hypnosis. The second one was much more difficult and difficulties. So Kilian gave me some signaling with his hand. And I had, unfortunately, to switch anesthesia for several minutes. And first of all, I counted this like a failure of myself not to have achieved enough deep trance for this situation. But we just continued when he woke up to continue the hypnosis, to continue his story, and then he came back to us and he told us that he wants the race, and he had the number 10 on his arm, and he was really happy, and then all the staff in the operating room applauded for him. There is a patient I will just very quickly. So this is an 8-year-old boy. I tried to do hypnosis, but I absolutely failed. He went into his story, the PVC line was no problem, but after he panicked and nothing else was possible, so there was no hypnosis for surgery, and we had to switch into general anesthesia, but he was happy after this general anesthesia because he had a story before, and in his mind, perhaps in his dreams, he continued his story, and he had even given the pony he was riding a name, and this was the pony with the white mane. You can also change the team spirit, but I will go faster. When I made hypnosis here in Paris, I worked for 5 years here in Paris at the Necker Pediatric University Hospital. So we applied hypnosis in the OR, and this changed everything for the whole staff, for all members. So even other people who hadn't any hypnotic competence, they changed their behavior, they talked differently to patients, they began to sing children's songs, they put out colored sticks that the children can color themselves their facial masks, so they put them into an active way and a choice of color, so this is not a passive suffering. Well, my conclusion is that we all know that hypnosis is suitable for a lot of anesthesiological settings, and my message is also that when you use the hypnosis in your field of competence, like anesthesia or something else, and you don't make any experiences with me like psychotherapy or something else, when I just rest in my field of competence, there is no risk at all, and I combine hypnosis whenever I want, whenever it's suitable, at any moment. So I can optimize and change my patient's experience and improve also his healing process. So hypnosis is not an universal remedy, but it's a very, very important and additional piece in my toolbox. So hypnosis might also be indicated in very unusual and also unexpected settings. Remember my hiccup patient, nobody expected that I will do hypnosis, and I didn't expect that my hypnosis will work that good. So very often in our anesthesiological settings, the application of hypnosis is very predictable. You have to react very often spontaneously, and sometimes you just have to be at the right time at the right place. So dare it, do it, take your chance. And the most important is, we come back to the expression of the hypnotic approach. It's not important that hypnosis itself takes place like you have planned it to do, and it's not important for the invasive procedure is a deep enough trance achieved, and if there's additional analgesics or sedation necessary. It's not important if there's need to switch to general anesthesia. Any deviation from previously planned procedure is not perceived as an adverse sentiment by the patient. So the important thing is the empathy, building up a trusting therapeutic relationship. It's important to minimize the negative experiences and the emotional relief of our patients. So the keywords are confidence, respect, support, and accompaniment. The slogan is just change the experience. The only thing what it's important is how the patient lives and defines his experience, and that he has the impression of being understood, that he is soothed and attended to. So go for it and change the extremely unpleasant to an easily accepted. There, the therapeutic mixture in all anesthesiological techniques and combinations. Don't become unconfident by an apparent failure. And don't declare the hypnotic trance to be your leading goal, but a positive overall experience for your patient. So come back to the question, trance or no trance, this is not really a question. The actual hypnotic approach makes a difference, and there is no failure, trust me. Thank you very much for your attention.